हेलो गाइस, गुड मॉर्निंग। कैसे हैं आप सब? लेट अस नाउ स्टार्ट विद अ वेरी short, sweet, and a very common topic that we hear in our surroundings, which is tetanus. Why so common? Because जब भी आप कहीं गिरते हैं, मिट्टी में गिरते हैं, रोड पर गिरते हैं, आपको चोट लगती है, then first thing that the doctor says after your dressing up is tetanus का इंजेक्शन लगवा लीजिएगा, and वो लगता भी बम्पर है, so everybody remembers that. Now, tetanus, which is caused by Clostridium tetani, is an obligate anaerobic gram-positive bacilli. Now, the spores of Clostridium tetani are terminal spores and round spores. This gives this bacteria a characteristic drumstick appearance. This was discovered by Shibasaburo Kitasato in 1889, and the habitat is that this bacteria is ubiquitous in soil, hospital settings, human and animal intestines. The diseases which are caused are the disease caused is tetanus, acute disease with muscle spasms and autonomic disturbances. यहीं पर एक बात करनी important है that tetany and tetanus are different. Tetany is caused due to deficiency of calcium. हाँ, उसमें भी muscle spasms ही आते हैं, but that is different as compared to tetanus. Now, the pathogenesis of the disease, the toxin is tenatolysin, the role of this is that is hemolysin with no role in pathogenesis. Okay, then another one is tetanospasmin neurotoxin that is responsible for clinical signs of tetanus. What are the properties of tetanospasmin? Antigenic, it is neutralized by antitoxin and it becomes a toxoid when treated with formaldehyde. So this is used in vaccines, all that tetanus vaccines that we give, that is used in this, and it is a plasmid coated toxin. So what is the mechanism of action of tetanospasmin? Firstly, it binds to the receptors polycyanogangliosides on motor neurons. Then becomes the internalization of toxin, due to which there is retrograde transport to the central nervous system. There it blocks the release of GABA and glycine, which are the inhibitory neurotransmitter. So the excitatory functions takes over and the result is uninhibited muscle contraction called as spastic paralysis. Now the mode of transmission, Clostridium tetani enters through wounds. Injuries like puncture wounds, abrasions, road accidents, surgeries done without asepsis, neonatal tetanus, which is caused by contaminated instruments, unclean delivery, or otogenic tetanus via the chronic otitis media. All these are the routes by which the bacteria can get the entry to the body. And tetanus is not contagious. There is no person-to-person transmission of this disease. What are the clinical features? It is the incubation period of the disease is 6 to 10 days. As shorter the incubation period, more severe will be the disease. The early signs are there is masseter or the locked jaw, also known as trismus. There is neck stiffness, back pain, and dysphagia. In neonates, there is poor feeding and body stiffness within the first 2 weeks of life. Now the progression, there is localized tetanus, spasm in one limb, then it becomes generalized as descending spastic paralysis, or in which hands and feet are spared while all the other parts of the body are involved. There is hyperreflexia and clear mentation. There is not altered mental state. Now, in autonomic nervous system disturbances, especially in the second week of severe disease, are BP fluctuations. Sometimes the BP is high, sometimes the BP is low. There is tachycardia, intestinal stasis. The bowel movements become slow or they even stop. There is sweating, there is an increase in tracheal secretions, and acute renal failure may also be seen. What are the complications of this disease? It can result in rhizus sardonicus, which is grinning facial expression due to facial muscle spasm. The patient looks as if he is smiling, although the patient isn't. The muscles have become spasmed. And there is classical tetanus sign, that is the tetanus को हिंदी में हम लोग धनु रोग बोलते हैं. Because in tetanus there is an appearance of the bow, because the hands and feet lie on the floor while whole of the body is makes a shape like a semicircle. So that is what the classical tetanus sign is being called here. Now for tetanus toxin action, we can remember that Clostridium tetani enters through from soil or wound, then it releases tetanospasmin, which retrogradely is transported to the central nervous system. There it blocks GABA and glycine, which results in spastic paralysis and autonomic dysfunction. So the organism responsible is Clostridium tetani. The toxin is tetanospasmin neurotoxin. Antidote by wounds, surgeries, umbilical stump. Key symptom is that it causes lockjaw trismus and muscle rigidity. There is neonatal sign is poor feeding. Complication is rhizus sardonicus or autonomic instability. The spread is not person to person, and the prevention is by tetanus toxoid vaccine, which is a toxoid form of vaccine, not heat killed or attenuated organism. It is a toxoid. We will see more about it. Now there are something known as opisthotonus and respiratory complications. What is opisthotonus? That is what I was saying. It is characterized by generalized spastic contraction of the extensor muscles. Body forms a rigid, backward arched posture, which is classical in severe tetanus and common in generalized tetanus. Okay, now if the respiratory muscle gets involved, the spasm of diaphragm and accessory respiratory muscles will be there. It may cause life-threatening airway obstruction and requires early airway management. What about the epidemiology of tetanus? In the global and Indian scenario, tetanus is more prevalent in developing countries due to warm climate, rural areas with fertile soil and unhygienic surgeries or deliveries. According to 2018 WHO report, there were 15,103 cases globally, and 7,046% of the total cases were from India. India reduced the incidence from more than 45,000 in 1980s. Why? Because we have expanded immunization of tetanus vaccine. Now laboratory diagnosis, which is the important part. The specimen is the excised tissue from deep necrotic wound, and wound swabs are less reliable for this. In gram staining, we see that it shows gram-positive bacilli with terminal round spores and drumstick appearances there. But this is not definitive because similar non-pathogenic species also exist, like Clostridium tetanomorphum. So what we do culture. Culture on Robertson cooked meat broth, blackened meat particles are seen, and foul odor is observed from the broth due to proteolytic activity of the Clostridium. On blood agar with polymyxin B, there is anaerobic incubation and swarming growth is there, typical of Clostridium tetani within 24 to 48 hours at 37 degrees Celsius. There is something called as toxigenicity test, which confirms if isolates produce tetanospasmin. It is performed via mouse inoculation using serum or urine of the affected individual. Now what about the treatment of tetanus? Passive immunization antitoxin is the mainstay of prevention because tetanus is better prevented rather than treated. HTIG, human tetanus immunoglobulin, is the preferred vaccine. ATS, equine derived anti-tetanus serum from horse, is also given. Okay, so HTIG is given IM 250 international units in 30 days, and there's no significant side effect. In ATS, the dose is 1,500 international units, duration being 7 to 10 days. There is risk of serum sickness or anaphylaxis. Intrathecal administration is more effective but less commonly used. Okay, now combined immunization ideal for non-immunized individuals. TT vaccine is given in one arm and HTIG or ATS is given in another arm, followed by complete TT course. Now, antibiotic therapy can be given in the affected individuals. Goal is to reduce the bacterial load and prevent toxin release. The drug of choice being metronidazole for 7 to 10 days. Alternatives of this are penicillin, doxycycline. Antibiotics do not neutralize the existing toxin. It can just prevent more release of the toxin. The supportive measures, of course, we have to take supportive measures like airway support, tracheostomy or intubation can be done and has to be done in many cases when the respiratory muscles are involved. Antispasmodics are given, like diazepam for muscle spasm is given. Autonomic control is done by beta blockers. Wound care management, of course, there has to be surgical debridement of the infected wound because वहीं से bacteria ने enter किया है. Next up is environmental control. We have to isolate the patient to avoid stimuli triggered spasm. And clinical tetanus does not confer immunity. Okay, so vaccination must be completed post recovery. There is nothing called as immunity from the tetanus happening to you. Okay, now the prevention of tetanus, we have discussed the HTIG and ATS vaccines. Other than this, we have the TT, which is the most common vaccine in the national immunization schedule as well. It is in two forms, monofilament, TT alone, toxoid is given with alum, and it can be combined with diphtheria and pertussis, given as DPT, and TD, tetanus and diphtheria, or pentavalent, in which diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenzae B vaccine are given. Now, the national immunization schedule is important to remember for this. The vaccine is given as pentavalent at 6, 10, 14 weeks. It is given as 2 booster doses of DPT within 16 to 24 weeks and at 5 years of age. And at 10 and 16 years of age, 2 doses of TD, tetanus and diphtheria, are given. What's the site? In infants, it is given on thigh, intramuscular, and in adults, is given on deltoid, and sometimes also given on the bum of the person. Okay, now the protective titer is, it should be more, the concentration of the vaccine in the blood should be more than 0.01 international units per milliliter. Now the post-injury tetanus prophylaxis. What's the vaccine status? If this vaccine status is complete in less than equal to 5 years of age, any wound, you don't have to take any action. If the vaccine status is more than 5 to 10 years and the wound type is tetanus prone, we have to give TD. Okay. If the vaccine status is more than 10 years and the wound type is tetanus prone, we have to give TD plus HTIG. And if there is unknown or incomplete vaccine status, we do not know about it, then any type of wound we have to give TD plus HTIG. Tetanus prone wound is a deep, more than 6-hour-old contaminated wound with burns, bites, etc. Now, prevention of neonatal tetanus. Neonatal tetanus is also called as 8th day disease because it arrives after a week of delivery. What's the WHO definition? It's the loss of ability to suck or cry between day 3 to 28. It is followed by rigidity and spasms. The common cause are the infected umbilical stump. Example, cow dung application. If done on the umbilical stump, it can result in infection. Or other unsterile circumcision or ear piercings also can lead to tetanus. There is a seasonal pattern seen of the disease that is more common in July to September. The prevention measures include 6 clean delivery practices. Yeah, so there can be practice of 6 cleans of the delivery practice: clean cord clamping, clean surface, all that. Clean hand, surface, blade, tie, stump, and towel. There should be a promotion of hospital-based deliveries, and TD should be given to pregnant women, 2 doses during the 2nd trimester with a 1-month cap. Now, what is the elimination criteria by WHO? Less than 1 case per 1,000 live births per district will be considered as elimination, and 90% TD coverage in pregnant women, these are considered, and 75% attended deliveries. All these contribute to the elimination part of the tetanus. India achieved neonatal tetanus elimination in 2016. Only 129 cases reported in India in 2018 versus 1,803 globally. Okay, so this completes your chapter on tetanus. It is not a very big topic, but yes, it is quite important and it can be asked as a case. So an essay writing exam question is on post-injury tetanus case. A person develops trismus, muscle stiffness and dysphagia 3 to 5 days after a bullet injury. Lab reveals gram-positive bacilli with terminal spores. What's the probable diagnosis? It's tetanus by Clostridium tetani infection. Describe the pathogenesis and clinical features. As we have studies above, like in pathogenesis, we will say about tetanospasmin, which blocks GABA and glycine. It causes spastic paralysis, descending pattern of muscle involvement is there. In clinical features, we will see trismus, lockjaw, opisthotonus, and rhizus sardonicus. Generalized spasms and airway obstruction will be seen. Autonomic instability will be seen, like tachycardia, hypertension, and sweating will be there. In neonates, an inability to suck or feed plus body rigidity will be there. In lab diagnosis, the specimen taken is deep wound tissue. On gram staining, we see gram-positive bacilli with drumstick appearance, drumstick spores, and culture is anaerobic blackening on Robertson cooked meat broth, and mouse test is done for toxigenicity. Add a note on vaccination. We will talk about TT vaccine, which is the toxoid form for active immunization and also a part of national immunization schedule. And other accessory vaccines are HTIG or ATS for passive immunization. The schedule for TT is pentavalent at 6 to 10 weeks, TPT boosters at 16 to 24 weeks and 5 years, and TD at 10 and 16 years. Post-exposure, depending on the wound and vaccine history, we can give TD plus HTIG. Okay, so this in the normal unimmunized individuals, and if the person does not know the history of how much the case was done and how much the extent of wound was there and how much is the immunization history of the patient. Okay, so this completes your tetanus part, which is the 72nd chapter of your book. Okay, next up we will be covering viral meningitis. So meanwhile, like to subscribe. Thanks for watching, and do study this from the book as well.